Good morning, everybody, and welcome to this seminar on what best practice looks like in adult social care. My name is David Pearson, and I was the chair of the COVID-19 Social Care Support Task Force, which met from the middle of 2020 and provided some of the support to the government on the winter plans that have subsequently been published. And I also have chaired since the beginning of January a Vaccine Boosters task force, bringing together all the national organisations across the NHS and across the social care sector and across government to help support the move towards helping to get social care service users, residents in care homes and staff across the whole social care sector with the booster vaccination. I know that we have this webinar at a time when many people have worked incredibly hard across the sector and across the NHS in very challenging times to make sure that social care service users and staff are protected as much as possible. And today we have an audience or a webinar consisting of people from the NHS, people from social care, both providers and local authorities, who are helping actively to support this venture. And I wanted to thank you for that fantastic work in extremely challenging times. This seminar is designed to support that work. The Boosters Task Force was established because although we've done incredibly well in the previous doses 1 and 2, boosting vaccination rates were low and continue to need to improve. But what I've been very conscious of is the fantastic work that I've heard about up and down the country across NHS, social care, in all its areas, which has been quite remarkable really in all the circumstances that we face. In hearing about that work, what we have found is that there's lots of sharing that would be useful, and we have formulated that into a document about best practice, which is being launched today and is on the will be on the Skills for Care website. And our intention is to talk through that today, to give you that opportunity to hear about this firsthand, and hopefully to take the document back and the examples and just double check your practice in your local area across health, across local authorities and providers, to check that everything is being done that can be done to support the social care sector in this important venture. I'm also acutely conscious that this webinar takes place at a time when the government has just announced that it is seeking to go to consultation on revoking the vaccination as a condition of deployment provisions, both in social care and in health. Clearly, what we know today is that the virus has changed significantly over the last 18 months. And in the last year, we've had Alpha, Delta and Omicron as variants. In terms of Omicron, what we know is that although it is much more transmissible, in other words, it infects more people more easily, the proportionate impact on it in terms of serious illness and mortality is less than the other variants. But it is nevertheless still a dangerous disease. And of course, we do not know whether there will be variants in the future. There have been 3 in the last year, so evidence suggests that there will be more, given the sustained community transmission across the world. So although the government has taken the view that would not be proportionate to continue with vaccination as a condition of deployment, or at least that it's necessary to consult on whether it should be revoked, it is still nevertheless the evidence, the scientific evidence tells us that it is still one of our major tools and weapons against the virus. And we only have to think about when the task force I chair was established in the summer of 2020, that we were on the back of a devastating and traumatic level of death and ill health across the sector, both amongst service users and staff. So we need to continue to do absolutely everything we can in order to ensure that we are safe, and it is one of those provisions. We know, for example, that the evidence is that it protects, with the booster, you get a 90% protection initially against serious illness and death, from 30 to 40% with just 2 doses. And from 5 to 9 weeks afterwards, you still have an 85% protection, and then it settles down at 70% thereafter. So it does wane, but it still provides a significant amount of protection. So we also know that it helps us with preventing long COVID. There is scientific evidence to that, and there is increasing evidence of, although it doesn't entirely protect against infection and therefore transmission, that it does provide some protection against infection and transmission. We have published some new messages as a result of the work of the task force on this, so that people in local areas, local managers and systems have those scientific messages about what the evidence is telling us, so which will support you in helping people to become vaccinated. So going back to this webinar, our purpose is to help to provide the best evidence we have from across the country, that in fact you have provided to us, about what works. And the paper also contains some very good case studies from across the country. In terms of this today, we're going to quickly get on with our speakers. So I'm very pleased that people have been able to join us to provide input to this webinar. We're going to have Dr. Adrian Hayter in a minute, who is a GP partner of Runnymede Medical Practice, the National Clinical Director for Older People and Integrated Person-Centred Care with NHS England and Improvement, and has made a huge commitment to the provision of vaccination and across the social care sector over the last 18 months. His work has been extraordinary in supporting this. Then we have Sarah Bellers, the Director of Infection Prevention and Control at NHS Frimley Clinical Commissioning Group, to talk about the work in that area. We have Stephen Chandler, Corporate Director of Adults Social Care, Housing and Housing Services at Oxfordshire County Council, and this year's Association of Directors of Adult Social Services President. And when we will have a question and answer session where Sarah Liskinen-Keel is the Vice Chair of the Home Care Association Board, and Martin Green, Chief Executive of Care England, will also join us. So without further ado, I would like to hand over to Adrian Hayter to kick us off with what good looks like from an NHS vaccination programme perspective. Adrian.
Great, thank you very much, David, for that introduction. I hope that you can see the slide that I'm sharing. Hopefully that's up on your screen. I wanted to just introduce myself. I'm a working GP, and I've been a GP for 25 years at the Runnymede Medical Practice in Windsor, and part of the Frimley Health and Care System. And I'm also the National Clinical Director for Older People at NHS England and Improvement. And firstly, I wanted to say that this kind of pandemic has really showed how we needed to get together as real communities to be able to deliver lots of different things. But the vaccination programme is one example of how we've had to work really closely with other people. And when the government and other people say that the NHS has done a great job in terms of the vaccination programme, I always think to myself that actually we haven't done it in isolation. It's actually been done because we are embedded within our communities. The NHS is part of everybody's community, and general practice, the specialty that I'm in, is actually the core unit of that. So really, this has been done in collaboration with lots of different people. And the example around the sector that we are working in, working across health and care, is that example of how this programme has relied on those close working relationships. And so when we think about what good looks like, I put it into the context of that. I first came across the vaccination programme I first came across COVID nearly 2 years ago. And I was in a care home working as I did on the with the care home, and they'd called me in to see a few patients who had been unwell. Some of them had had viral illnesses, and this was 2 years ago in about it was March, and those people who I went to see were fairly well, not too unwell, and the nurse just before we left said, "I wonder whether you could just see this one patient who I'm also a little bit concerned about. She's got a rash on her legs." And so I went to see her, and when I went into the room, she looked really well. She didn't look unwell. She was breathing normally. She wasn't distressed. And the nurse, Kelvin, took me to her. We looked at the rash, which was a rash on her legs, and she had mottled skin. And for me, that was the first sign of what I'd read about, which was silent hypoxia, meaning that people don't have enough oxygen to make the skin pink and well perfused. And I knew that she was seriously unwell, and when I did a few tests, including an oxygen saturation test, I found that her oxygen levels were very low. And fortunately, I was able to get hold of her family. We made some good decisions. She decided to stay in the home. We kept her comfortable, and unfortunately, she died the next day. So that was my experience, my first experience of COVID in the pandemic 2 years ago. And at that time, we didn't have regular testing in care homes. We didn't have regular testing of staff. We could rely on some PPE, and we needed to train ourselves up to understand how to use PPE much better. And Sarah and others in our commissioning area supported us in that, and with the care home staff as well. And then later on, we understood much around kind of how we could distance and how we could support people by distancing. And then in December, really, of that year, we started to really have the opportunity to think about another layer of protection in terms of the vaccination programme. And that's when the vaccination programme was launched. And the two people in the vaccination programme, the clinical lead, Dr. Nikki Kanani, and Emily Lawson as the NHS England lead, really have taken this programme. And the philosophy of the programme is to become embedded within communities, to work using general practice and all the other hospital sectors to be able to vaccinate according to the JCVI, the Joint Committee of Vaccines. And what we know is that they provided a framework for us to be able to provide vaccination to everyone. For the care home sector, we had that initial vaccine, which was really designed, the Pfizer vaccine, for mass vaccination sites. It was a new vaccine to us at that time, and where we had to work out a way of getting it to the care homes, because care home residents and the staff of care homes were identified as one of the areas that we needed to vaccinate first. So we managed to set that up and set up a system for vaccinating in care homes. And when Nikki asked me to do that, we set out some trials, some very rapid evaluation of trials of care homes and general practice across the whole country. We had 7 areas where we looked at, and we did that rapid evaluation over a period of a week, and then wrote the SOP, the standard operating protocol for it. The key thing there, and my key learning from working with those 7 sites, was the importance of the relationship between the care home manager and the vaccinating teams and the public health teams and the social care teams around those care homes. And in the STOP, it was reflected in that, in the visiting procedure, in the good communication, in the preparing for a visit, and in the return and cyclical visits that would happen. And then since that, we've gone on to learn much more about how we should be vaccinating, but how we can be really inclusive around understanding this population, understanding the population we need to serve, and understanding how to get vaccination done in the right way. And although I've talked about care homes, this is not just about care homes. It's about also getting the vaccination to those vulnerable people who are living in their own households and maybe receiving social care support as well, and getting the vaccination to those people and their carers is really important. And so we've gone through, and as David said, we've had to adapt to different types of variants of this virus, and we are having to understand and learn on the job, but also rapidly deploy not only the first vaccine, the second vaccine, thinking about having the booster vaccine, which is to protect from that primary course, to give further protection, because we know that things are changing. We know that the vaccination effectiveness changes after time as well. So that adaptation is really important in terms of the booster programme. So it's really important that we recognise that here we are in this slide showing that we've got the vaccination programme and the delivery model, which is from a central control, and we've got the national support, we've got regional support, and we've got local vaccination centres. We've got the primary care networks, is the groupings of GP practices and community pharmacy as the delivery for some of this work. And that we use things like roving, going out to different sites, not only to care homes, but to other sites, to sheltered accommodation, to shopping centres, to places where people actually need us to vaccinate in the right kind of way. But all of this is locally owned by the whole system around the people that we're looking after, and that's a health and care system. And for me, the other thing that I really kind of noticed in terms of what goods looks like is we're dealing with outbreaks sometimes in care homes, where actually the care home, not only one person, but several people might be affected. And what do we do in terms of vaccinating to protect the people in the care home when there's an outbreak occurring? And we came up quite quickly with some guidance around that from public health and working together. And once again, it shows us how important it is to consider when we're vaccinating in an outbreak, to not to say that it's not impossible to do that, but to take a risk assessment approach, which involves the local director of public health, the CCG, which is the commissioning group supporting that, the local vaccination team, and most importantly, the care home, to make it safe for those residents to be vaccinated, if possible, or to have a period of time to wait until it's safer to be vaccinating everyone. Not only from the viewpoint of the residents in the care home, but also from staff coming in and out of the care home during an outbreak. So for me, what good looks like is that collaborative effort and that collaborative arrangement which occurs. The next slide, if I can move us on, just shows us really the different routes that care home staff can receive vaccination. And this absolutely applies also to thinking about care workers in the community as well, getting vaccinations, visiting the walking vaccination sites, having us making sure that they're able to get the vaccination as easy as possible by having a fast track for either care home staff or home care staff. Getting direct invitations. Sometimes GP surgeries are having the opportunities to vaccinate at their surgeries or to one of the local vaccination sites, and then having the scheduled visits to the care homes. And for the booster vaccine, which is what we're talking about now, we're able to make sure that people have that access, and that the priority is for residents, people who are older, who are living in their own homes, and for the staff who are looking after them. And actually what we know is that by getting the booster out to people, we are reducing the transmission, and we're reducing the risks of hospitalisation to those vulnerable people who we're looking after, and also protecting ourselves and other staff. So for me, that whole system approach is really important, and I'm sure that Sarah and the team, Sabahat and the team from Frimley, will be able to give us more information as we go on. Thank you, David.
Thank you very much indeed, Adrian, for that. And of course, what this exemplifies is that what we've learned over the last 2 years is that it takes all of the partners at a local level and indeed nationally to make a success of this. So it's the NHS vaccination programme, its providers, its local authorities, and in that regard, in the paper that we are publishing today, we've suggested that creating the right confidence levels and making the vaccination as easy as possible for people to access, and communicating regularly in terms of updating people and about those opportunities, and indeed any concerns that people might have about getting a vaccination or booster are absolutely critical in taking this forward. So when you come to the paper, and which I hope you will all find useful, you will see sections on communication, on the role of providers, on operations and use of data and so on. So lots of things for people to look at there. I'd now like to, though, move on to introduce Sarah Bellers, the Director of Infection Prevention and Control at NHS Frimley Clinical Commissioning Group and the COVID-19 vaccination lead. So Sarah, over to you.
Thank you, David. So as you said, I'm Sarah Bellers. I'm Director of Quality and Nursing for the Frimley CCG, and I've got my colleague with me, Sabahat Hassan, who is the Inequalities Lead for our programme. So if we move to the next slide, please, Sabahat. So where is Frimley? Frimley is in the southeast region. We've got a population of 850,000. That might make you think that it's quite an easy system to manage and to get people to take up the vaccines. We do have our challenges. We have we're made up of Bracknell, Windsor and Maidenhead, Slough, Surrey Heath, North East Hampshire and Farnham, and from that you can see that we span 3 counties, which you can imagine has its challenges. So if we move to the next slide, please. So within the system we have a number of statutory bodies, and I think the thing that makes some of our challenging complexities is around our local authorities. We have county, unitary and district, boroughs and councils. This means that we have 3 DPHs, 5 public health teams and 5 local authorities to work with, which actually is a challenge, but it's also a huge opportunity and has been an absolute boon for sharing, learning and rapid spread and adoption. So out of adversity, out of challenge comes adversity and challenge, so that's great. So move to the next slide, Sabahat, please. When we started looking at the programme all the way through and right through to the booster part of the programme, we used our system ambitions and our absolute principles of what we do about our system. Our relationships are central to what we do and how we work, and we always work with our communities, however large or small, to understand, develop and build on what's already working. And that's really important when you think about our 5 places and how different they all are and what different solutions that they all need. And because we have this overall ambition that we will increase overall healthy life expectancy and reduce the difference in healthy lives lived for our residents, we are all really committed across the system to doing this. And I think for me, that's been the easiest part of doing this. There have been many challenges being the SRO for this programme, but that commitment to want to do the right thing for our population has really come through from every part of the system that we've worked with. Can we move on to the next slide, please, Sabahat? So how have we done this? How have we done this joint working? So we have joint strategic and operational meetings, and that with the 5 local authorities is a challenge. So we have to attend 5 of their different meetings and they have to attend our meetings. It makes it quite big, but actually that's great because we absolutely share everything. We have a shared comm strategy and align ourselves even across different ICSs, which is really great for the patient population. Can you move on to the next slide, please? I think some of the obstacles that we face, having 5 different places and communities, and we have got very affluent areas and very deprived areas, very different cultural areas and things, and that makes it a real challenge for how we think about how we communicate. And so we have to really understand those different places and know what we're doing. Another thing has been throughout this programme is keeping it fresh and learning from across the system, which is a benefit of being able to learn from other areas, and being ahead of the cohorts and understanding the difference between cohorts, because actually age does make a difference as much as anything else. And that's really been something that we've had to do each time we've done it, whether it's first, second, or the booster. Next slide, please. Sabahat. So thinking about what we talked about what is our system, we've gone for hyper-localised vaccination offers, making sure it's easy for people to access, and lots of walk-in options. All of our primary care networks across our system have been really engaged. They know their population, they know their patients, and they have worked with us really well to invite, persuade, listen to, talk to, and really try and help get every member of our community vaccinated. We really have this saying that nobody gets left behind. We have community pharmacies and one mass vaccination centre, but mainly we've had this really local targeted offer. Next slide, please. When we were thinking about the boosters and how we got to take up the update, as Adrian said in his slide, that all of the groups were important, including the housebound residents. This came at a real time of trying to drive the booster programme, and it was really difficult trying to do the housebound residents as well, because in the first and second vaccines, it wasn't too bad because a number of services weren't operational, and so people had capacity. By the time we were doing the housebound residents this time, actually that capacity was truly stretched, so we had to think differently about how we would do it. So the PCNs, as they had done before, went and visited the truly housebound patients, but those where they were less housebound, and I suspect most people have had the occasion where they've gone to a housebound patient and found that they're out shopping or something. That wasn't the first time I'd heard it in the first or second times. We really encourage those to take up different transport options, and we supported those transport options, really helping them to get to our centres so that we only really visited the truly housebound. And actually we had a really great uptake of the housebound. Can we move to the next slide, please? I'm going to hand over to Sabahat now really to talk about that localised provider snapshot.
Thank you very much, Sarah. I hope that everyone can hear me. It's lovely to join you guys today. We're going to give you a very brief example of how we've worked within RBWM. And the reason why we've chosen RBWM is just because of the huge amount of care home support and care homes we have within this one place. So like Sarah said, we've got 5 places, but if you look at RBWM in a snapshot, we've got 39 care homes, 11 LD homes, a hospital care home, and 27 old people's homes as well. A huge number of beds, and alongside with that, you know, a large capacity of staff within these care homes, and relatively positive uptake. If you look at our care home providers, we've got 93% of the employees have had first and 91 second doses and boosters as well. So it's a good example for us to bring here today. Just a little bit about how we've been working with our care homes across the patch, but within RBWM as well. So we absolutely made sure that we were in coordination with our local authorities and with our care homes about the best way to be working with them. And we had the best channel for communication was for us to join their existing meetings that we had to really make sure that we were working within the most supportive way. So we have direct and very strong relationships with our care homes, but we made sure that we were using those channels that were most easy for the care home managers and the systems to work with. We made sure that we were doing a lot of listening, as Sarah was saying, and really understanding hesitancy, and understanding where is the hesitancy. Is it at a leadership level, or is it actually at an individual level? So, for example, we were made aware that there was a care home manager who was hesitant. And so after some discussion and some guided conversations, that when that leader came on board, actually we saw a really big increase in the uptake of the COVID vaccination within that specific care home. So that was really, really positive, and really, really insightful was to understand actually each care home is a mini community within itself, and we have to look at it in that way. So there are trends within each care home about what the key hesitancies or concerns may be. And it might be because a particular care home is staffed with a particular demographic. So we had one care home, for example, where we had a much younger cohort of carers from an Eastern European background. We understood what their concerns were, and we were able to go in and provide a bespoke offer around some awareness around pregnancy and fertility, for example. And again, that generated some very positive results in terms of vaccine uptake. Obviously, we use the capacity tracker for really targeted support, and made sure that all of care home staff, as David, as you said, it's that access, it's making sure they knew where and when to get vaccinated. So we had, the vaccination teams were going in to vaccinate the residents, but actually the offer was there, we're going to vaccinate your members of staff as well at the same time. But if that's not easy for you, if that's not going to work, here's the list of walk-in sites, here's how you book. And if you are turning up at a walk-in site, actually, just take your ID with you. You don't have to wait. We will see you at the front of the queue. So really that kind of supportive environment in terms of access. As I mentioned, absolutely continuing to use trusted information from those known partners. And our medicines optimization team have been amazing. They've really been able to run bespoke sessions for each of the care homes and for the care home managers to really ensure that everyone is able to speak confidently about the vaccine programme. And if there are myths, the managers within the care homes are able to address some of that. And where not, then come back to us. It's a very, very two-way relationship. I think the PCNs have been amazing. So as Adrian was referring to, really having that strong relationship, and I've actually seen Adrian in one of the care homes and working very closely with members of staff that have had, for example, some hesitations, and then being able to address that and seeing the impact that has had on that particular individual, but also wider than that. And then, being able to be there, do the ward rounds, go round and see those new patients and new members of staff that have been coming in, and making sure that everyone's vaccinated. Key learnings and tips. So I think we tried to just put 3 here. Insights. I think for us, a key thing was understanding what are your drivers, what are motivating people to get vaccinated. And we did a campaign called People Like Me, where we showed people, members of staff, residents, young people, old people, and had their own words. So people like me, and a quote and a photo of that person. Then it wasn't NHS speak, it wasn't Department of Health speak, it was their own words and why they were motivated to get vaccinated. And we really saw that was working. That peer-to-peer kind of comms and engagement really does work. And with the insights then, actually, what is your hesitation? What's stopping you? And ensuring then that the messages, the engagement is really targeted, because people are just going to switch off from listening if actually you're not telling them what they want to be, or what they need to be hearing. Again, the communications was very live. We have weekly steering group meetings, primary care networks, care homes, the trust would come together and say, this is what we're hearing, these are the concerns, and we would be then responding with really strong communications, picking up on that. And we would tally that up and marry that together with feedback we were hearing from Health Watch and some of our other community partners as well, to really make sure that the message is complete and effective. One example was we had some concerns, feedback from some groups saying, actually, some members of staff from care homes are saying, actually, we don't want to take the vaccine right now because I'm planning to get pregnant. When I get pregnant in a month or two's time, I'll get vaccinated once I am pregnant. And we were saying, okay, so that's a particular message there from that insight. And then we had the other group who were saying, actually, I don't want to get my vaccination when I am pregnant, but I'm happy to take it in the run up to that. So that just shows why it's really important to have that insights-driven communication to make sure that there was a really complete message to understand at a really micro level what's happening. And I think the last one was persistence. It's that never give up approach. And that willingness, if you like, to try something new. If it hasn't been done before, let's give it a shot. You know, there's lots of different examples I could give you. Last night we were on YouTube Live, and it was something we hadn't done before. We had a panel of experts there to take questions from. We had a particular cohort within Slough where we know that the uptake wasn't particularly good, and we really wanted to try and understand and address some of the concerns and hesitations. We had a panel of experts there, and they were talking about everything from fertility to consent, to all of those kind of questions that we know, and it was a really engaging session. So that persistence and that willingness to try something new. One of the examples that we can bring from Aldershot was really how they engaged with their local community. It was really age and community specific. So they did a lot of outreach to the local leaders. We knew that the Nepali population would need that little bit of additional support to come through the door to get vaccinated. So they made sure that their site was central. It was a really well-known and easy to access location. They had a Nepalese interpreter on site. So it was someone that was well known. It was someone that could facilitate those conversations and make sure that it really was a comfortable environment for people that were coming in. And it really built those, you know, those relationships with ourselves and our local Nepalese population. And we've got to a really positive point within that. So I think that's a really nice example there. I'm going to quickly pass on to Sarah now, just for our last slide. So over to you, Sarah.
So really, we just wanted to say the results and benefits of our approach have been really great working, even better, great working, cohesive, joint working relationships across health and social care and with our local population. Really, our ambassadors that we use are just amazing and really help us to do it. And that's helped us to reach our mutual aim and ambitions, which is to increase that vaccine uptake across all areas of our population, trying to leave no one behind. So thank you.
Thank you very much, both of you. That was very helpful and informative. And I just wanted to prompt people that we have a Q&A session coming up in a bit, and some people have started to populate the Q&A, the questions bubble on the webinar screens, which you can access. So please do let us have the questions. I also wanted to say that in the paper we have examples from all over the country, from the four corners of England and the bits in between. So you will find some more examples there. So I'd now like to introduce Stephen Chandler, the Director of Oxfordshire and also the President of ADAS. Stephen, over to you.
Thank you, David, and good morning, everyone. I've been asked to take you through what a well-functioning local vaccination system might look like. And in fairness, I think my job's already been done for me, because listening to Sarah and Sahabat, they described a really great experience. But however, let me use up my time, hopefully constructively. And before I do, let me just say a really big thank you to everybody who's on the audience this morning for everything they do to help ensure the residents, the citizens, the staff that they work with have the greatest chance to be healthy and safe during this. So as David said, I'm both the Director of Adult Services in Oxfordshire, but also the President of ADAS. So whilst my presentation will have a strong lean on what we've been doing in Oxfordshire, you can equally read this as happening across the country. So as we've already heard, it is really, really important, and was really important for us to establish a system-wide approach to vaccination. And we did that as part of our ICS, because our ICS, which is called lovingly Bob, covering Buckinghamshire, Oxfordshire and Berkshire, covers, as you'll have picked up, more than just Oxfordshire, but we established a vaccine group in Oxfordshire, led by one of our district council chief execs. So empowering local government to take a lead in what might have been seen as an NHS responsibility. And that was really, really important, because it really brought alive that this was around our citizens, and whether they happen to be people in receipt of support or actually providing support. And that vaccine group has been operating right throughout from the beginning of the vaccine programme. It's not only led by the local authority chief exec, as I said, but has our care provider association firmly embedded as a key member of that. And that's really important, because, as I said at the beginning, leadership cannot be underestimated in this. And that leadership manifests itself in Oxfordshire in a variety of different ways. As you've heard, it often takes the form of being a key supporter and educator on the importance of vaccine. I'm the Director of Social Services, as you know, so therefore I'm very, very keen to understand vaccine in the context of care homes, home care, but also staff. And therefore, for me, approaching this not as a requirement or a condition of employment, but rather as a condition of helping ensure the maximum amount of people have the protection that the vaccine provided, that David took us through right at the beginning, was so important. So we didn't approach vaccine as a compliance issue, but rather as a public health and well-being issue. And I think that's really, really important if you want to engage constructively and positively with your public and your staff. We, like we've already heard, used individuals to tell their story. Oxfordshire was no different. We had concerns from individuals who were planning to get pregnant or who were pregnant, and one of our most effective champions in reassuring there was one of our workforce who actually decided during her pregnancy to get vaccinated, and she was able to have the conversations with people around the analysis, the consideration that she'd done, and why she decided to take the decision to have the vaccine. And again, that's just one example. We use lots of individuals to tell their personal stories as a means of providing both reassurance and understanding, because I'm sure nobody on the call is going to be surprised, but sometimes people are wary of a message coming from somebody like me because they think I've been paid to promote that message rather than actually believing it as passionately as I might appear to. So it is about using every resource you've got to accurately get across the importance of those messages. We didn't do YouTube Live, but that's a great tool to have in our armory. We did a number of webinars with our care home sector and our care workers, using our public health colleagues to provide both the evidence base and the transparency. We not only did them live, but we recorded them, and then we had them available for people who weren't able to attend. So there was those messages, those individuals talking about it were there to be used as widely as possible. So of course, everybody's doing that, but we also tried to ensure that we were getting really into the experiences of our providers. So we were talking to providers routinely and regularly. Routinely and regularly in Oxfordshire means weekly and daily. Now we were doing that to both understand the experiences people were having, the challenges, and to hear from our providers what we could do to help overcome some of those. And we did the usual things that people have been encouraged to do, paying people time to come to our talks, ensuring people were being paid for time if going to have the vaccine wasn't something that was physically possible during their normal work. And sometimes people say it's not just about the money. Of course, it's not just about the money, but sometimes the money is the critical factor. So we didn't shy away from that. One of the things that helped me feel confident that we were making a difference was data and really using the information that was available. Now, I have been probably as critical as most around some of the accuracy of the tracker, but let me just say the data we use comes directly from the tracker. So we've worked with our providers to help ensure that that data was an accurate reflection of what was happening in Oxfordshire. A lot of that was around education, understanding, practical support for some providers who were really struggling either to access the system or to have staff to be able to ensure the data was on there. We did all of that because, for want of a better term, the tracker is the Bible we use in Oxfordshire to tell us what's happening. Now, I will be honest, we had one or two, and I think it was 4 providers that really were not delivering against the tracker requirement. The data was not going on. And despite our arm around the shoulder, our support, our understanding, the data wasn't there. So we had to use a little bit of stronger persuasion. This is for 4 out of about 300 providers, so it's a minuscule amount. And that persuasion was to say, actually, we're going to withhold IPC funding because one of the requirements is that you keep the tracker updated. And we withheld it for a few weeks. That ensured that we felt confident that everybody was using the tracker. I'll just say again, for emphasis, minuscule amount of our providers in Oxfordshire, but it's a tool we had in our toolbox, and we used it as we needed. Finally, what I would say to you though is it's really, really important that vaccine is amongst the top priority in your list of priorities. So within adult social care, we have a daily focus on numbers to ensure that we're making the progress that we needed. When I mean we in adult social care, as the director, I see the daily increase in numbers. It's reported to me on a daily basis because for me it is that important. It's that important because I wanted everybody to see how important I was taking this. That's so as I could ensure that problems were being addressed, support was being provided, and the progress was being made. I'm really, really proud of the work that we've achieved in Oxfordshire, not Oxfordshire County Council, Oxfordshire as a system, health and care system. Yesterday, 98% of our care home residents had the first vaccine. The 97 had their second dose. 91% had a booster. It's brilliant. 97% of our care home staff had first vaccine, 96 second vaccine, 54% booster. Our home care staff, and we know how home care staff perhaps haven't had the same focus. 91% of our home care staff had their first vaccine, 88 second, and 53% booster. So numbers that are really, really great because they reflect the importance that people are assigning to getting vaccinated and keeping themselves and the people they work as safe as is possible. So I finish where I started, emphasizing just how important leadership is in this. And leadership doesn't come necessarily from people like me. I would call out our Home Care Association in Oxfordshire as providing real system leadership on this. So Eddie McDowell, if he was on the call, he might be, if he is, I'd call out the work he's done to really help the sector understand the importance and support that. So I've just seen David drop off the call, which is a little bit worrying, as I was hoping to hand back to him having finished my session. So that was all from me. Can I check who's taken back? Is that you, Ruby?
Yeah, you can Jack, if you can hand back over to me, that would be great. Thank you.
Thank you, Ruby.
Hi everyone, my name is Ruby. I work in the Adult Social Care Vaccines team in the Department of Health and Social Care. And while David is not on the call, I think we've come to the Q&A section. So thank you for everyone that's shared questions in the chat, and do continue to do so. We have had one question come through which says, how can we support staff to get the booster if they have concerns about severe side effects? Who would like to take that question?
Ruby, would you like me to do that?
I think that's one for you, Adrian. Thank you.
Okay, thank you, Ruby, and I've been trying to answer the questions in the chat as well as we go along. But really, this is a really good question actually, because I think it does occupy a lot of people's minds, and the worries and concerns around side effects. And as a vaccinator, I've been to vaccination sites and people have expressed the same concerns, and we've talked it through. The first thing I'd say is that in medicine, a lot of people will have a medicine or a vaccination, and actually most people don't have any real side effects at all. But it's important to recognise that some people will, and usually, and in the experience of the vaccination team, is that actually most side effects are very mild side effects, and in the majority of cases, most people complain of a numb arm, or sometimes having a bit of a fever for 1 or 2 days and feeling unwell for 1 or 2 days, and then they recover. And then their immune system then will gather momentum over the next few weeks to get that protection into their bodies against COVID. So that's the usual case. And very few people have very severe reactions or effects on the vaccines, and it's very much a very rare event to happen. And usually if it's an allergic type reaction, the vaccination site or the people doing the vaccination will have the equipment to deal with that, and it's a very rare event, and one in hundreds of thousands of people rather than one in a few people. So actually that's the context is really important. I think the other thing in terms of supporting people is listening to that concern and giving them the right information, and maybe just giving it to them, not necessarily once, but a few times, to be able to give that message across. And also, this is really where the care sector can really help, is the information that say care home managers or other people have can reinforce that. So there's lots of leaflets and around kind of symptoms which people can share. And if people hear that from the professional that's supporting them, as well as read about it, then they have much more confidence in the vaccine itself and the side effects. One of the things that came up, Ruby, was the if I'm going to get the booster, will it cause me to be unwell and cause me to be off work because I'm unwell? And especially over Christmas time, I think this was a concern that a lot of our staff in care homes and in the care sector had, because they didn't want to let their residents down by being off sick. And what I was saying to people is actually that's a less common thing to happen. And within the care home, actually by doing the vaccination programme and spreading it out over 2 or 3 weeks, then it minimises the risks of a lot of people being unwell all in one go. So that's why, once again, it's really important to work with the care home provider as well, to say when people should be going to get the vaccine, making sure it's supporting the staffing, and really that care home manager or that manager who is supporting all the staff is the other key person to give information to the staff member.
Thank you very much. Thank you very much, Adrian, and I'm very sorry, colleagues, on the webinar. My computer just spontaneously crashed, so I've now reignited it and we're back on. I just wanted to also next just turn to Sarah and Martin as people who have not spoken to us previously this morning, and just to ask them for their reflections on what is important here and the things that they think are important about the booster, but also about the approach to ensuring that people are supported to get it. And I wonder, Sarah, if I could start with you, if I may. And I've been aware of videos and work that the Home Care Association has put out around particular testimonies from frontline staff about what getting the booster meant for them. And so I know that you and Jane Townsend and others have done a lot of work on this, but I'd just like to invite your comments at this point.
Well, thank you, David. Yes, morning everyone. My name's Sarah. I'm the Vice Chair of the Home Care Association. My day job is as Chief Operating Officer for Agencare Group. We're a reasonably sizable social care provider. The Home Care Association has routinely and persistently been saying that vaccination is extremely important. As health and social care providers, our membership has a duty of care to the people we provide services to, and to our own staff, of course. And there is considerable evidence, as has been shared today, of the benefits of vaccinations and boosters. So our position in the association has long been, though, that should ideally be done by persuasion, cajolement, good information, rather than enforced. And many of my observations are that the materials that we shared as a result of this, and the fine report as a result of the work that David Pearson and his colleagues have done, excellent tips, pointers, undoubtedly, and these are things that work. I think in representing a membership of very small providers right through to very large providers, I think we shouldn't underestimate the challenge that exists for some providers to even assimilate such rapid changes in policy, to assimilate and implement a variety of good practice that there is. And certainly one of the things our members particularly appreciate is the digests of policy that they receive. And in that great variety of social care, the ease with which we can assume an understanding from all sorts of people that might not be there. Anecdotally, I personally have had experience in the last 10 days of adult social care directors saying, well, what's the problem with the vaccination in social care? They're all vaccinated anyway, aren't they? And that's because, of course, in care homes, that has been the rule for some time. And this sort of lack of understanding that that's not the case, or hasn't been the case in home care. The difficulties of addressing vaccination and boosters and communications in what is basically hundreds and thousands of lone workers either living in with their clients or visiting their clients for short periods. These are very different challenges to those facing both the NHS and care homes or building-based care services. And also even some of those building-based care services like extra care schemes and supported living locations, they too, if they're not separately registered and on the capacity tracker, can actually be missed in terms of some of the initiatives. So from the Home Care Association perspective, we are entirely committed to supporting our membership through information, advice and guidance to increase their vaccine uptake, using all of the methods of communication and cajolement that are in the reports be available to, if not now, then soon. And I just would say that it isn't very easy. We've even heard today a lot of reference to care homes and not a great deal of reference to communities beyond perhaps some general population activity. And I think that one thing I would say, perhaps to be helpful, is that it might be very good for commissioners and local authorities to really perhaps, as I think it does mention in one of the papers, think about which of the providers in your areas are capable and competent to be relied upon to follow through on these things. And organisations such as that I work for, we have a reasonable overhead support structure. We can manage to maintain that important data that Stephen just talked about and follow through on processes. But there are a lot of smaller providers who would really struggle with that. And then it is possible perhaps to target the integrated care support arrangements around vaccination and booster to those who are likely to most need it. And certainly utilising associations like the Home Care Association and Care England, undoubtedly our circa nearly 3,000 members really value the way that we can help them digest what is necessary and what good practice looks like.
Sarah, thank you very much indeed for that full set of comments, which is very helpful. Martin, can I introduce you now to cover the same issues? Thank you.
Thank you very much, David. And I'm Martin Green. I'm the Chief Executive of Care England, and I also chair the Care Provider Alliance, which is a group of representative bodies. And our members in the Care Provider Alliance, people like the Home Care Association, we deal with older people, people with learning disabilities, people with mental health needs, and also, of course, people with physical disabilities. So we see the whole spectrum of social care. Exactly as Sarah said, we are really supportive of the idea of everybody getting both vaccinated and boosted. Of course, in residential care, things are slightly different because there is now a legal requirement to be vaccinated. But I don't think that should stop us from making the argument and making sure that everybody had a full information so that they can make informed decisions about the booster. I was really impressed by colleagues from Frimley because I think they really showed the way in which they were, first of all, being very clear about information. They were engaging in real partnerships with their social care providers and indeed with their communities. They were making sure that there was a lot of really useful information when people were asking questions. And I do think it's really important to be able to respond to people really effectively, as Adrian said earlier, when they ask specific questions, because people do have concerns about things like vaccinations. I think there are also some practical issues because, as Adrian said, the idea that there would be side effects, they might affect a few people. But of course, if you're trying to manage a staff team, I know it's the same in home care as it is in residential care. If you have your entire team vaccinated at the same time, that might lead you into some real challenges around staffing, etc. So getting people to be able to talk through what might be their contingency plan if they did have a couple of staff off, and making preparations for that. And where possible, trying to plan and time the approach to vaccination in very flexible ways. I also thought it was great in Frimley, the way in which they had so many different ways in which people could access the vaccine. They were talking about going into places where people were, so they were in their workplaces, but also making sure there were fast track facilities in some of the vaccination centres, etc. And all these things make things easy for people. I also think Stephen's point about how important it is to get the data around who has been vaccinated so that we have a really clear idea of where the challenges are and where we can focus our attention if we're going to see pockets of areas where there are, should we say, vaccine hesitancy, we can then address those. So getting the data sets is really important. I think one of the things that we haven't done enough of is use the Care Quality Commission, who do have a complete register of all registered services, and we need to use more effectively their channels of communication to cascade information. So I think also Sarah's point was well made, that there are some really great, very practical examples in the document that's just come out today. So I'd urge people to get that document because it really shows in different parts of the country, in different services, in different settings, how people have responded to making sure that everybody understands the need for a vaccine and a booster, and then helping them to make it as easy as possible to get that vaccination and booster, and also to get information if they have any concerns. So I think all those things together will lead us to be able to get to the place where we want to be in terms of the majority of the sector being both vaccinated and boosted. Thank you, David.
Thank you very much, Martin. Thank you very much indeed. So I just want to pick up a few themes that have arisen in some of the questions that are on the question and answer site. And I think there are a number of issues that people have raised. Some of them are around the concern that particularly care homes have about staffing and the impact of the previous VCOD, the vaccinations and condition of deployment, the policy that has been in place. And concerns about the process or around the current consultation. And I think it's fair to say that it's right to say that there was a letter sent out to all providers yesterday on halting the current employment processes whilst the consultation takes place. And then there is another set of questions, and so there will be more information that becomes available during this period, immediate period, about the consultation process. Clearly, the impact of COVID has been extremely difficult for the sector in lots of ways. It's been difficult in the sense that it has made demands on people that have been extraordinary, that we wouldn't have anticipated before, from having to wear lots of PPE, to the consideration of vaccination in order to protect ourselves, but also the people we work with, and requirements that have been set in place. And I don't underestimate the challenges and difficulties and pain that has arisen from that. But in all of that, what we have to weigh up, or what's had to be weighed up all the way along the line, is balancing those issues of difficulty against the very dramatic impact of the virus. And my review of the winter plan that was done last time indicated that at one point in April, there was a 251% increase in care home deaths compared with normal. We also found that there was obviously a very large number of deaths in that first wave. And by the virtue of the things that were put in place during the following months over the summer, that reduced significantly to around 25 to 26% and was below the international average. And that was before the vaccination. Since vaccination has been in place and people have been largely vaccinated, that has reduced further, and actually rates of death and illness have kind of tracked along with what were close to what was being the average for previous periods pre-COVID. So there's no doubt that a mixture of PPE, the vaccination, has made a huge difference to the sector and made it more possible to lead more ordinary lives without, notwithstanding the very difficult situation that we still experience, the risk that we still have. So why is the vaccination still important, people are asking? And the good practice paper is about obviously helping people to get the vaccination, and addressing concerns is part of that. And you will see that in the many tools around communication and toolkit, which gives the scientific evidence as well as the narrative about why this is important. But clearly, we start with the fact that social care workers look after those people in our society who are most vulnerable to the serious consequences of COVID. And as I've said, the evidence that I've suggested, we cannot underestimate that. So it does help to reduce the impact of that on both the people who use services and the staff, who are, by virtue of the nature of the role, more likely to get be in significant access to the people who might have the virus. It's also, I suppose, better for the service, because what we know is that the levels of protection stop people from becoming sicker than they otherwise would, even if they do get infected. And therefore, time off is less, the impact on the individual staff is less. So there also stops social care staff from becoming seriously ill with COVID-19, because there have been people who are seriously ill from COVID-19. My own mother was in a care home until she died recently, and one of the members of staff was in an intensive care unit in that first wave for 14 weeks, and the impact of that was significant. So we have to remember where we have come from in order to understand what we need to do to continue to protect ourselves and actually ensure that we're providing the best services for the people we're here for, which is the people who receive those services. So vaccination isn't the only defence against COVID, but it is a significant defence, and I believe that the scientific evidence is quite strong, albeit that because of the changed nature of the virus and the particular circumstances of Omicron, it is not felt justified to proceed with VCOD. And I recognise that for people who have been through vaccination of condition of deployment in care homes, both managers and staff, that's a difficult pill to swallow. I appreciate that, and I don't want to duck that. But what I would say is, what we must do is think about what's in the best interest of the people that we serve and the staff who work in it. And I have absolutely no personal doubt, having been part of this struggle, both nationally and locally for the last 2 years, that is in our best interest to think about how we best support the sector to get vaccinated. And that's why we want to hold this webinar, and that's why we want to promulgate the paper that we're issuing today. So I hope that helps to, I'm sure it won't satisfy some of you. I'm sure that some people will still feel dissatisfied with that, but I think that's the best, honest, most authentic answer I can give. So what I would like to do now is to move back to some other questions, and I just wanted to ask Stephen Chandler about, if you don't mind, Stephen, just to say a little bit more about your thoughts about the importance of the booster and the vaccination, but also what are the sorts of examples that you've come across of where people have had any issues which they're concerned about but have been helped to overcome them, and work that perhaps has taken place at Oxfordshire or indeed up and down the country by your colleagues.
Yes, thank you, David. I think in a way you've articulated what lots and lots of us believe and feel passionate about, namely that the vaccine is one of the most powerful weapons we have in both keeping people healthy and reduce the risk of transmission, or should an individual catch COVID, reduce the risk of serious illness or ultimately death. So in a way, colleagues like myself have been doing their utmost to try and ensure that message gets across to people in whatever language or format that is likely to be conducive to making them feel able to take the choice and have the vaccine. However, as everybody has said, uptake is proportionately related to education and convincing people that it is the right thing to do, rather than instructing people that you must do that. So our success in helping people who have been hesitant or people who have been against the vaccine has been very much seeking to understand the reason why that hesitancy exists, and helping to reassure, educate, overcome that. I gave an example of using one of our colleagues in Oxfordshire who was pregnant and was considering vaccination, and ultimately made the decision that yes, she was going to be vaccinated and was vaccinated, to share with others her thought process, her consideration, the advice she took, the information she used in order to make that decision, and her experience of having the vaccine and what that was. Because as I said earlier, that is always the most powerful way of getting it across. Somebody that you can relate to, you can recognize in the person in front of you. we've also used the fantastic resource that is our public health colleagues to help take through the science, because there are a large number of people out there who really want to understand the science before they'll go and have that, and it's about using that, and of course the relationship that exists between the GP and all of us is sacrosanct to this. Being able to leverage some time from our GP colleagues to educate, to reassure, and to help people make the decision, it's a nightmare, because I've yet to meet a GP who says I've got nothing to do. They are all so busy, but true to form, they have been prepared to give up that time. So it has to be a combination of those, and it's a bit like a lot of things. Don't assume that if somebody's hesitant or resistant that you are going to be able to provide either the reassurance or the education in one go. Sometimes you have to keep going back and helping people make that. So, when we were vaccinating staff teams in care homes, there were a proportion who said no. We didn't just give up, we went back. We went back time and time again as doing that. So in a way, as I say, you've got to start from an assurance and understanding of the importance of vaccination, and then you've got to tailor at in every way possible the messaging, and in a way, never give up. So all of those, David, have helped, and I've used Oxfordshire, but I hear exactly the same stories from Leeds, from Cornwall, from Frimley as that.
Thank you very much, Stephen. Thank you. Adrian, I'm going to turn to you next. I've got a few questions that I think you might be able to help with. And if I just cover those. The first is, has any been, and I'll give you all three if that's okay, Adrian. Has any benchmarking been done of other vaccine programmes, flu, to know what is good take up? And I've got some thoughts on that one myself, so I might come back in on that one. Secondly, if care homes are struggling to get vaccination administrators, i.e. those who can administer the jab to the home to administer the jabs, it actually says jabs in arms here, who should they contact? And then there's another question, which is, I have been asked by a young care worker with if the vaccine could potentially have adverse effects on her menstrual cycle after vaccination, concerns future fertility impacts and so on. And that there is some suggestion that there have been some reports internationally of bleeding in postmenopausal women. So any thoughts on those, Adrian? Much appreciated.
Okay, thank you, David. I'll try and get through those three questions. Really good questions, actually. The first is around evidence from vaccination programmes. So I think this actually links into why we're trying to do this, is kind of and support people in getting vaccinated, because they're not only protecting themselves, they're protecting their loved ones around them at home, but also protecting the people who they're working and caring for. Something that Kelvin, that nurse that I spoke about really early on, has been repeating in his messages to his colleagues, and he did something recently on our NHS blog. So that is really important. We've actually got this as a kind of working to protect the residents that we're looking after. And if that's in a care home or if it's in a hospital, what we want to be doing as healthcare workers is improving the vaccination rates of us as staff, so that we don't transmit, and so that we protect the people we're looking after. Now, the scientists will say that really you need to have really good coverage, 90% really, or 80 to 90% of staff being vaccinated, to be able to protect that kind of that community, either in a hospital or in a care home. And so in the vaccination programme, we're looking at that for COVID, and we think, if we're getting vaccination rates of above 90% for the residents, and above 80%, and really if we can get it close to 90% for staff, then what that means is that we're protecting that group of people who are living and working in that care home from having outbreaks which occur and then which cause more transmission in that closed environment. So whether it's flu vaccination or whether it's COVID vaccination, we should be aiming to get those rates up. Now, the health service have been doing this in hospitals and in other settings for quite a long period of time, and every year we look at that and we look at the vaccination rates in hospitals, and through good campaigns and through good working in those healthcare settings, we've found that those rates have increased, and actually when they used to be only kind of 40-50%, that actually there's been a lot of trusts who are getting kind of 90% of their staff vaccinated. This was before COVID. So actually we know that we can get those rates, but it's really through good organisation with those by those providers to be able to support that staff vaccination programme. Now for flu, we know that because of the pandemic, the flu that we normally get at this time of the year has been not around, mainly because the overwhelming nature of the COVID virus. But it's something that we fear because flu also causes care home deaths, and it also causes deaths in people who are carers. I'll give you an example actually. In the NHS, we try and vaccinate carers and also care staff. And one of my patients who was a carer was offered the vaccine. He didn't take up the vaccination and he ended up on an ITU being mechanically ventilated. And this was a few years ago. So that was devastating to his family because he was a carer and he was caring for someone else. And so the importance of getting vaccinated is against flu is really important. So we're aiming to do that in all settings and get as many people to take up the vaccination by using the same principles that we talked about today for COVID vaccination. So that's the vaccination question. The second one, I think that you asked was around the reports for the person who was worried and concerned about the potential symptoms on her menstrual cycle, and the menstrual and actually questions from women around their concerns around fertility, around concerns around how it might affect them and their periods, how it might affect pregnancy, have been one of the concerns that have been kind of coming through on the programme, but one of the concerns that we've known more and more about. And as you say, kind of having, as Stephen was saying, around being protected in pregnancy is really important because you're more vulnerable to the devastating effects of COVID in pregnancy, probably because of the immune system and how the immune system is working in pregnancy. So it's really important that for women, they know that they should be vaccinated in pregnancy and have early vaccination if at all possible. But also for all the other women's health concerns, fertility is one of those. And there's some really good information on the Royal College of Obstetricians and Gynecologists, our Royal College, the experts in gynecology, and I'll put that in the chat, who've answered those questions around the menstrual cycle, around concerns around future fertility, and they've produced some blogs and videos as well. The professionals who deal with that day to day are really advocating that people get their vaccination, and usually side effects are minimal. It was one of the questions that was asked to me when I did the last second care home vaccination, and when Sabahat actually was down at the home, I had a discussion with someone around her worries and concerns about fertility and menstrual cycle, and she ended up having the vaccination. The vaccination offer is an evergreen offer in the NHS, so don't be afraid if it's your first vaccination, your second vaccination or your booster vaccination. You can get your vaccination at any time when you're ready, and it's important that people know that they can come forward with that. But the concerns around fertility and women's health problems can be answered more specifically by a local health professional. But I'll put some information on the chat from the Royal College of Gynecologists, which will be really helpful. So there was a third bit, wasn't there, David?
Well, about the other thing was where people have, if somebody's not coming, they're not having enough visits to get the.
Oh yes.
Who should they contact?
Yes, so this is really important that, as I described in that first slide, we've got local vaccination teams who are groupings of practices where there'll be a local vaccination site. They'll be the people who usually organise the vaccination visits. If you're not really kind of getting through to the person in that local vaccination team and not being able to communicate with them, then it's the commissioning group. So it's groups like Sarah, who was on earlier, who have the responsibility for vaccination. And I'm sure they'll be able to have that conversation with the local vaccination team to be able to support the specific issue that you've got in your local home.
Thank you very much, Adrian. And on that, in the paper, we identify the importance of having local authority and integrated care system leads who are known to all the providers, who they can contact in situations like this. So actually our paper addresses the question of making sure that there are people to contact and that people know, and that is communicated. We're now sort of 2 minutes away from the end of the webinar, and I want to just bring this to a conclusion now by first of all saying that in relation to your questions, we have tried to address as many as we can in the time that we've got available. I think Adrian particularly has been very active in responding in real time in writing to the questions, things like what's happened in the NHS in relation, compared with social care, and obviously replicating the processes that we're talking about today. We've got the paper that's out that you will now be able to access, and it's got lots of useful links attached to it, which cover many of the issues that we have raised. We're also recording this webinar so that it can be seen by other people who are not here being able to join us today. The final thing I wanted to do was to thank Stephen Chandler, Adrian Hayter, Martin Green and Sarah Liskinen-Keel and our colleagues from Frimley for their presentations and the answers and contributions at the Q&A session today. But I also most importantly want to thank you, all of you attenders, for attending today, but also for the work that you have done every day and over this period and in the future, both in providing the best services we can to the people who need social care services, but also ensuring that the social care sector is protected in all sorts of ways in its important venture and mission to provide those services. And we hope that the paper that we have provided today, that the webinar today, have helped in that mission. And so thank you very much indeed, and I now bring the meeting to a close.